our colleague and friend, Dr. Paul Park, who's going to be our guest lecturer today. As you know, he is a graduate of the University of Michigan Medical School, got his MD degree there, and then did his neurosurgical residency here at the University of Michigan. He subsequently did his specialty training in complex spine surgery at Cleveland Clinic, and then did a further additional training in minimally invasive spine surgery at the Sims Murphy Clinic. He has since that time come back to the University of Michigan and is an associate professor in the department. He has a practice that encompasses a full spectrum of the care of patients with spine disorders. His main clinical interest is in the area of degenerative spine trauma, and spinal tumors, and certainly in the area of spinal trauma is where we get the opportunity to interact with him. His research interest is broad-based, includes impact of minimally invasive spine surgery and surgical outcomes, as well as the biologics of spine fusion. He's also taking the lead in looking at issues related to recovery and spinal cord injury, and is the principal investigator of the 2 trials that are now undergoing at the University of Michigan, and he's here today to talk to us about that. So, Dr. Park.
Thank you. I really appreciate the opportunity to give this presentation. I'd like to thank Tony Kyoto, who for inviting me. I've known him for a number of years now, and is always very helpful, and we've worked together on a number of projects, and so I do want to thank him for this opportunity. Now, so this is kind of a broad, I would say a broad field in terms of potential treatments that are sort of ongoing or on the horizon when it comes to spinal cord injury. And I think you could spend a lot of hours actually talking about it, but I was just going to focus, like Tony had said, on the 2 projects that are going to occur at the University of Michigan. One is ongoing currently, and one probably will start, I would say, in the next month. I mean, it has to do with IRB and budgeting, and then we'll have a site initiation visit, I think, within a month. So we're about to start that. So I'm going to really focus on those 2 topics. Here are my disclosures. The only thing that was relevant, stem cells is a sponsor for one of our studies, but it's grant support, it's institutional support, and none of the other disclosures, I think, really impact this talk. And I think in this audience, everybody's probably aware of all the basics, but I thought I'd briefly go over it. Just I wasn't sure who was going to attend. But the incidence of spinal cord injury, if you look at most statistics, is about 54 cases per million people in the U.S. And assuming that the population is 314 million, these are 2016 numbers, that would be about 17,000 cases a year. Although if you actually kind of look at the literature, there is relatively recent, like 2010, 2012, it was more like 12 or 13,000 cases a year. Prevalence is estimated 282,000, and that's, again, based on 2016 numbers. The average age of injury is 42 years presently. In the last several years, that's the average age of injury, but in the 1970s, it was 29 years. So, we're dealing with an older age population now. Degree of injury, again, just a few basics just to set the tone. When you're looking at how patients present after with a spinal cord injury, the most common presentation, at least in 2010, was incomplete tetraplegia, about roughly half, or 45%. Next most common was incomplete paraplegia, and complete paraplegia, and complete tetraplegia. And we do, at our institution, see the spectrum of this, and I would agree that incomplete tetraplegia is probably the most common presentation. The question is, why is there normal in here? Well, I mean, there's some people that present with a spinal cord injury by the time they're discharged are normal. And you could argue if this was real or not, but they do include that in the statistics. It's not very high incidence of that. Cost of spinal cord injury, I think, probably many in this audience is aware of this. It's expensive, unfortunately, condition to treat. And it really depends on your level and degree of injury. So if you're high tetraplegic, it's estimated to be about just over $1 million in your first year of care, and then a couple $100,000 after that. So if you're injured at 25 years of range, you're looking at about $5 million of care. And with decreasing injury and decreasing levels, obviously the cost does decrease. But the one aspect of this sort of cost analysis is the fact that they don't include lost wages, fringe benefits, loss of productivity, so it's actually quite a bit more expensive probably than these numbers would suggest. Yes? Oh, I'm sorry.
We can't hear you very well.
I apologize. Let me see. Hello? Hello? Is that better? Okay. Sorry about that. I apologize. In terms of the cost issue discussed, so life expectancy, I think this is not surprising. And again, just like cost, it depends on the level of injury and the severity of injury. So this is breaking down to several age groups. So if you're injured at 20, and so if you're age 20 and you don't have spinal cord injury, your life expectancy is about 60 years more, so about 80 on average in terms of when you typically expire in this country. But if you have a spinal cord injury at the age of 20, again, it depends on your level and degree of injury. If you go all the way to the right here, at high tetraplegic with ventilator dependent, your average life expectancy is about 19 years, so not very high. But that's what one would expect. Whereas if you have just age of D injury, it's not changed dramatically. There's quite a bit of mortality in your first year after spinal cord injury. So if you make it out of that 1 year, the life expectancy does increase. So if you go back to the ventilator dependency, you gain about 6 years on average. So I just want to transition into the injury mechanism. Again, this is probably not anything new, but I just want to set the tone and where we're going with our newer treatments or potential treatments. So the primary injury or the acute injury is the initial event, car accident, fall from a height, often associated with a fracture of some sort in the spine, which can cause compression, contusion. It's an initial injury. There's not much you can do about it. Neural tissue tends to be pretty sensitive, so it's a direct injury. And that is represented as laceration, hemorrhage, edema, necrosis. So that's not anything you can really change. Events happen. The horse is out of the barn. The secondary injury is where everybody kind of focuses their potential treatment. Okay, and in the phase after the acute injury, you get more edema. Vasospasm is when vessels will kind of spontaneously narrow and decrease the blood supply, and so it's an ischemic problem. So less blood flow will result in further injury to the neural tissues, and that's been very well worked out as a prime problem. Excitotoxicity, inflammation. You get a lot of inflammation with the injury, with increase in your lymphocytes, and that could result in a bad microenvironment for healing later on. And you get this cavity that forms typically, and it's because neural tissue, when you injure it, a lot of times it doesn't heal. In other tissues, you injure it, and it just develops scar. So if you cut yourself, you'll heal, and you see a little scar line there. It's collagen deposition. It's just how you heal. When it comes to neural tissue, it just goes away. So if it goes away, it liquefies and just goes away, you're left with a cavity. And the problem with this cavity is twofold. One, you get these like abnormal astrocytes that surround the cavity once you get this cavitation occurring. These astrocytes aren't good people or good factors. What they do is release other materials and inhibitory factors like extracellular matrix, and one of the inhibitory factors that's released, and it's been looked at quite frequently, is chondroitin sulfate proteoglycans. And these are all sort of products that impede neuroregeneration. So the ability of neural tissue to regenerate is already poor to begin with. But then you have this environment with a host of factors that are inhibitory. It just makes it worse. And that's why healing after a spinal cord injury is actually fairly poor. And you also can get a glial scar forming at the site of injury, and it acts as a barrier toward nerve growth. So here's just a schematic diagram of that subacute to chronic phase. And so here's a cyst forming. This is, presumably the site of injury. The neural tissue becomes necrotic, liquefies, you're left with a cavity surrounded by these bad astrocytes. These astrocytes release factors that aren't good, and you get further injury to neurons. degeneration, so injury to the oligodendrocytes will result in demyelination and just worse injury. And same thing with the inflammatory response. The B cells and T cells enter, and it sets up a bad microenvironment and leads to further injury. And this is the natural process after an injury. So our current management, and this is what we do, someone comes in with a trauma, say fractures, clear-cut spinal cord injury. We take them urgently, typically because these fractures have ongoing compression for decompression and stabilization. The rationale there is, so the primary injury is done, but if you leave it in a state with ongoing compression and extra movement, it can result in further, traumatic direct injury to the spinal cord. So again, this is one means of preventing further secondary injury. Now, we can't do anything with, this type of surgery is not going to really do anything about that, necessarily the vasospasm, those other inflammatory responses that you get. But it's what we can do fairly easily, and it's something that it's been done quite some time. Blood pressure management is another issue. As I mentioned earlier, ischemia is a big factor. And a lot of these patients are hypotensive. There's this neurogenic shock that occurs with a high-level spinal cord injury. So their blood pressures can be pretty low. And if their blood pressure is low, you don't get as much blood supply in this area, and it could lead to further injury. So that's an important issue. Steroids have been looked at, and everybody's probably aware of it, quite specifically and extensively. And some of the early studies suggest high-dose steroids would be helpful, but that's been fairly debunked now. So it's not used very frequently, just because of the side effects of high-dose steroids. If it's a young person, I may be willing to give it just because the data is not conclusive. But if an older patient, there's so many risks with high-dose steroids, so it's typically not given anymore. And obviously, rehabilitation is very important for improved functional outcome. It doesn't really prevent a secondary injury, but it helps with whatever you have left. So what's the future look like? And this is, it's a long sort of intro, but, these are potential areas for treatment that are about to be studied or currently being studied. And again, I'm going to just focus on the two areas we're currently involved in. And that's in terms of enhancing neural regeneration, right? So one issue that occurs with the inflammatory response is you have release of factors that will activate Rho, which is an intracellular protein. And once Rho is activated, its role is actually to prevent or to result in growth cone collapse of the axon. So it prevents the axon from growing. And so, one of the studies that this is the study I was telling you we're about to start, is the Cethrin trial. And Cethrin is an inhibitor of Rho. And I'm going to get to this in a bit, but if you could inhibit Rho, you're going to allow axons to regenerate or give a better environment or promote axonal regeneration. And the cell-based therapies, this is a current trial we're undergoing right now, is very simply you're hoping to replace the cells that are damaged or gone away, have died off, or repair the injured cells. And also stem cells have been shown discrete trophic growth factors that allow existing cells to grow further, and I'll get to that in a second. So, so there's a lot of potential treatment targets, and again, we're just going to focus on the two trials we're going to participate in. But growth factors you could improve, do something with the lesion cavity, because this cavity is a barrier toward axonal regeneration. Axons will hit the cavity and can't grow across it. Right, so that's another area of research, which I'll touch on just briefly at the end. There's another company looking at trying to prevent this from occurring, but we're really going to look at axonal regeneration. So I want to transition to Cethrin. Right, this is the trial we're going to start, and it's based on this phase 1/2A clinical trial that was performed, I believe, about 5 or 6 years ago. This publication is from 2011. And it was a multi-center study of patients with acute spinal cord injury, AJAs. And it wanted to start initially, again, this is a safety trial, it's phase 1, with thoracic spinal cord injured patients, because if this factor was, like, say, neurotoxic, it's probably not going to result in too big of a deal if you have a complete injury in the thoracic spine. Whereas in the cervical spine, you may lose a level or two if it's really a bad, from a safety standpoint. So they initially started in thoracic spinal cord injury patients, then progressed to the cervical spinal cord injury patients. And the second phase was dose ranging trial. They wanted to find an optimal dose in terms of safety as well. And so, here's a mechanism of Cethrin. I explained earlier that, myelin-associated inhibitor, so this all has to do with the inflammatory response, active NOGO receptors to activate Rho, which is this intracellular protein, and Rho really results in growth cone collapse of the axon. And so Cethrin is a recombinant, human recombinant C3 transferase that inhibits Rho activation. And pharmacokinetically, it actually is very favorable for this, because if you just place it on a dura, it'll diffuse through the dura. It's a blood-brain barrier, but the Cethrin seems to be able to diffuse through it fairly well. And and once it enters the intrathecal space, it'll diffuse into the spinal cord parenchyma, and it'll get to where it needs to do its work. So from a technical standpoint, how you apply it is actually very straightforward. And so the point of the study was primary safety, and then secondarily they were looking at the pharmacokinetics, the immunologic parameters, and the neurologic outcome. I'm going to focus on this a bit. So this was not an efficacy trial. It was a safety and dose ranging trial. So if you look at it, they had 48 patients enrolled, 32 in the thoracic group. Again, they wanted to establish that it was safe, and then 16 in cervical. They had 35 patients that completed the trial, 23 in the thoracic, 12 in the cervical, and a few people died, not more than what was expected of a spinal cord injury. A few people lost a follow-up, and a few other, it said other reasons why they couldn't follow up completely, but they had a reasonable follow-up. A single dose of Cethrin was given at the time of surgery, from 8 to 146 hours from the time of injury. And the neurologic results, again, it wasn't a primary outcome variable, but it's an interesting, secondary outcome, but the results are actually very promising, and that's why a lot of investigators were focused on it. When they looked at the improvement in the ASIA scores, this is the ASIA motor scores, there was a particularly profound improvement, particularly in the 1 and 3 milligram dose group. So if you look at the chart here, 3 milligram, 1 milligram, you see 6 weeks after injury, the average motor score improvement, and I'm going to look at the 3 milligram group, is almost 10 points. By 52 weeks, this was out to a year, it was over 25. Okay, and outside this study, typically if you have a spinal cord injured patient who's an ASIA A, they will recover somewhat on average, but it's been described as about 10 motor points on average. But this was much more than that if you look at it. It averaged between 21.3 to 27.3, so they thought it was potentially a treatment effect. Again, this is not an efficacy trial, but it's very promising data. And they also noted that there was significant sensory recovery as well. When they looked at the Asia Impairment Scale, the AIS, at 12 months, 31% of cervical ASIA A's improved to ASIA C. And 2 patients converted to an ASIA D, actually, in this study. In the thoracic patients, it wasn't as profound. At 12 months, 6.3% of thoracic ASIA A's improved to an ASIA C, and 1 patient improved to an ASIA D. So everybody looked at these results, and again, it was not an efficacy study. And they were very, a little bit surprised, but also very optimistic. But the company that originally sponsored this trial didn't have enough money, so it actually lingered until Vertex, which is the pharmaceutical company that is a sponsor for this upcoming study, decided to license it and go further with it. So, these were great results, and everybody wanted to move to the next stage, but they were limited by funds and having a sponsor. But Vertex is a pharmaceutical company that has taken this over, and so this is a study that we're about to start within a month. It's the phase 2b/3, so it's going to be an efficacy trial, double-blind, it's randomized, a placebo-controlled trial. And I just want to briefly go through the protocol. This is from Vertex, and I just thought it'd be interesting to go through what we're going to do. Sorry, down here. So objectives are always efficacy and safety, but safety is always there, but efficacy is going to be the primary goal for this study. And here's the study design. It's going to include Asia or AIS A/B patients, cervical spinal cord injury, C4 to C6 motor, and we're going to include a pediatric population from 14 to 75. And the primary endpoint is upper extremity motor score. And dosing will be single dose during surgery. All these patients will have to have surgery, and which is pretty common anyway. Most people with a fracture will undergo surgery. And there's 3 arms. The 3 milligram group was based on a phase 1/2A study. This was the optimal group. But again, they wanted to see if a higher dose, and this was considered safe, would make the effect more profound. So there's 3 arms to it. 35 sites in the U.S., 150 subjects total is the target number, 12 months, and really double-blind. So this medication will come. I'll apply it. I won't know if it's placebo or not or what dose. Here's sort of the design schema, and again, 12-month follow-up. I'm just going to kind of scroll through these pretty quickly. So within the last month, the first patient was enrolled in the trial, so it started. We're going to be a little late because our IRB is a little slow, I think. Budgeting is always an issue, but within a month we should be starting. But so as far as I know, one patient has already been enrolled in the study. And they're looking at an 18-month accrual process across the 35 sites. And so, this is sort of a typical MRI you'd see. And so the design schema is very straightforward. They come into the ED, they get screened, and the inclusion criteria are fairly straightforward. You don't want to transect the spinal cord, obviously. You need some, continuity to do this. And this is actually very straightforward. I'm not going to go through it really. Here's exclusion criteria. This is pretty standard. They don't want transverse myelitis, acute discrimination, just traumatic contusions. Pretty straightforward. And so the study endpoints, again, they're going to have a host of endpoints, and I don't probably need to explain any of these to these groups, and probably know it better than I do, but the upper extremity motor score is going to be the primary endpoint at 6 months, but they're going to follow patients at 12 months. And, spinal cord independence measures, these are all functional outcomes for spinal cord injured patients. Also, sort of generalized health function, the SF-36, EQ-5 is maybe for, that's another sort of broad-based health measure on function. So they're going to look at a host of measures. The upper extremity motor score, again, I think everybody understands what this is. So I'm not going to go through all these. And I kind of want to just go through, again, this protocol. Like at the time of surgery, these are all just the questionnaires for them. So this is typical. This is probably a thoracic spine. So this is the screws and rods that you implant for stability, and this doesn't project very well. But a laminectomy has been done here, and that's a dura. Okay, so decompression's occurred, and so this product will be mixed with fibrin glue. It's a product we use all the time. It's a sealant for spinal fluid leak or sometimes for hemostasis. So we'll mix it and we'll just apply it, and it gels. So it goes as liquid, it kind of like epoxy. It just kind of solidifies, and it'll just stay in that area. And hopefully, it'll allow the medication to diffuse through the dura into the spinal cord. So that's about it for the study, and we're about to start it. So we're excited. I think everybody's excited to start it. Tony, Gianna, we're all going to be involved in it. Multiple other people in the group. So let me transition to a totally different study. So that was acute spinal cord injury patients we're treating, and for the stem cell study, yes.
Is there a level in the cervical that you were looking for, or?
Well, it just is dependent. C2 would be too high. So most of these studies that I've been involved in and I'm aware of, they don't want to go up above C5. Really, I mean C5 level. It might be C4 more. Only because they're worried about the diaphragm. So if you cause a problem, if they're not ventilator dependent, you may cause an issue. So it's typically they want the mid to lower cervical spine is where they focus their studies on. So this is the study that we're currently involved in. We've been involved in it for over a year now. And it's a single blind, this is the title of the study, randomized parallel arm, phase 2. It's really phase 2-3. They have several cohorts of study patients. And these are, and I apologize if anyone has an issue with it. These are human neural stem cells, and it's fetal stem cells essentially. And the other difference is it's in chronic spinal cord injury patients, so that's a target. So it's a different stage in spinal cord injury. Okay. And rationale is stem cell transplantation may improve recovery by really providing trophic support, releasing growth factors that may make the environment better for the existing cells and neurons and astrocytes to grow better. It can also alter the host environment for the same reason. These kind of two go together. And it can also replace neurons and oligodendrocytes, hopefully. That's the premise anyway. And it can be administered in acute, subacute, or chronic stages. And there's different rationales for why people think it may be better in a subacute versus a chronic stage. Some people think in acute stage there's too many things going on. You get this inflammatory response. Maybe the stem cells won't be able to grow or survive that environment. But there's different reasons. And we're going to really focus on the chronic group because that's the study we're involved in. And the study we're involved in, we're in the human stage, but it's based on a lot of the animal studies. And I don't want to go through all the animal studies because, even talking, everybody finds it boring. So I'm just going to highlight some of the key points here. So these were done in immunodeficient mice, and what this study just showed was that these human neural stem cells were able to survive, differentiate, migrate, and promote motor recovery. Again, in animals, though. You could stop aging in animals, you could cure cancer in animals, so it's all, you got to take that with a grain of salt. So, but that was a premise for the studies, and these stem cells are lineage limited, meaning they're neural lineage, so they can't differentiate into anything other than neural type stem cells, so oligodendrocytes and neurons, essentially. And this, I just took a slide from this study, and the stem cells are stained brown, will stain brown. So all this shows is this is vehicle placebo, this is human fibroblasts that were also used as a control or a comparative group, and this is the human stem cells. And you can see the stem cells survived. They also kind of are migrated throughout, okay? So these were injected around, this is a cavity that forms with the spinal cord injury, and they were injected perilegionally, and you can see how far they've traveled. So they survived, multiplied, and traveled. So all this was meant to show is they survive and migrate, okay? And this is what they differentiate into. Again, they'll stain brown. And in white matter, they differentiated into oligodendrocyte-like morphology, right? So they look like oligodendrocytes. In gray matter, they look like neurons, when they did the histopathology in these mice. Okay. And so that was a premise that eventually went to a phase 1 trial. And I'm not sure it was published. I was looking for it. I'm aware of the phase 1 group. It was done in Sweden, 12 patients, thoracic spinal cord injury, again, because they didn't want to cause a problem if this was going to be dangerous. So it was a phase 1 safety trial. So they implanted 12 patients with these stem cells, 10 million cells, essentially. And it was done in Sweden, and they found it was safe. And anecdotally, there was some sensory improvement in about 3 patients. No motor improvement, but again, I think it would be a long distance to travel for motor improvement for chronic thoracic spinal cord injury patients. And so that was premise for this phase 2/3 study, which we're involved in. And here's a protocol that they gave us. So a little bit different age group, 18 to 60. Their target enrollment was 52 patients. And it's 14 North American centers ultimately were involved, and we're one of them. So we were involved in the cohort 1 study, so we contributed 1 patient to the 1C group. And this was a dose tolerability arm of it. So they did 10 million in the thoracic group, but they were wondering if more cells were better. It's like everything else, more is better, right? So they wanted to see if that was possible. So the first cohort, not randomized, not blinded, okay? The first 2 patients had 15 million cells, and after the second patient was enrolled and they deemed it safe, the second 2B had 30 million cells implanted, and then the 1C, if that was considered safe, had 40 million. So we were involved. We contributed 1 patient to the 1C group and had 40 million cells implanted, and he tolerated it just fine. And so, with 40 million being tolerated, that was a set dose for the cohort 2, which is the efficacy arm of this, okay? And so we're essentially involved in this part of it, and we're right in the middle of it, closer, I think, to the end. They're looking for 14 more patients right now, 14 to 17, I guess, to finish it off. And so we've contributed 3 patients to this arm, and we're screening a 4th now. And so that's where we're at. So the primary objectives are, again, efficacy at this point, and safety is a secondary. And this is a design scheme, and I already kind of went through this, 15, 30 million, 40 million. They had a safety meeting, was fine, so we're in cohort 2 right now. And they're going to do an interim analysis, from what I understand, in about 3 months or so, to see how patients are doing. They wanted half the patients to get a 6-month follow-up, and then do the interim analysis. So this is kind of boring. Inclusion criteria is very similar. So the primary efficacy is the upper extremity motor score, the primary endpoint that they're following. And then a host of secondary outcomes, lower extremity motor score, EX grade conversion, GRAPS, spinal cord independence measures, SSCP. So just a lot of secondary measures, but this is primary again. And so the surgery itself, I wanted to, since we've been doing them, I thought I'd show a little bit more detail here. It's a posterior base approach with laminectomy, so removing the bone in the back of the spine. That exposes the dural sac. And unlike the other study where you just kind of lay on fibrin glue with the medication, this is actually opening a dura, looking at spinal cord, and taking a needle and injecting it into the spinal cord, which to me, during my training, you're not supposed to touch a spinal cord. It's pretty delicate. I mean, and so sticking a needle into it just seems wrong. And so it was a little bit of a barrier. And it requires 8 separate injections perilesionally. So I was initially concerned we'd cause more injury, not maybe distal to the spinal cord injury, but proximal to it. So, you could potentially cause more of an issue with a worsening exam. And but having done it now, it seems like it's fairly well tolerated. In fact, we get a post-op MRI, you can't really see that the needles were injected. This is one of the patients that was enrolled in our study. It's an unfortunate young man. Had a diving accident and had a C7-AGA injury. You can see he's had an anterior and posterior fusion. You can see a spinal cord. This is, I want to say 6 months or 9 months after the injury. And you can see all the myelomalacia here, the cystic cavity formation. And he was enrolled in our Cohort 1 study. And here's a video intraoperatively. So I'm going to orient you. This is to the head. This is to the feet. Okay, and the dura is here. So it's open. This is a suture opening, maintaining your dura opening. Here's a nerve root fascicles. So this was, I forget the level, but maybe C6, maybe C7, can't recall. So these are dorsal, so they're sensory. So we call this the dorsal root entry zone, where it enters the spinal cord. You don't appreciate it, but if you saw more of the view, you'll see this width is narrow. I showed you on that MRI, there's a lot of loss of spinal cord. So when we had the full view, which is not shown here, you can see that the spinal cord is thicker and wider above and below this. So this is the area of myelomalacia. So this is distal, and we're injecting just medial to the dorsal root entry zone. And obviously, you want to avoid a vessel for the bleeding aspect. But I'll play the video here. And so there's a lot of respiratory variation. So that's why the spinal cord moves with breathing. And this is a small needle, it's a 30 gauge needle, and we're injecting 70 microliters, which is a small amount. And any sort of small motion really, the syringe looks huge, the needle looks actually pretty big, but we're highly magnified here. And so, it's just picking a site and then just pushing a needle in. And then we're injecting, the guideline is inject 20 microliters a minute, which is very difficult to do because the syringe has a 70 microliter marking on it, and I don't know where 20 in. And you don't want to inject too forcefully. So these are stem cells suspended in solution, right? So it's eight injections, 5 million cells per injection site. So we have 4 distal injections to the injury and 4 proximal, and to me, it seems forever just holding this thing here. It's really a 5-minute total injection. And the reason why is they want 20 microliters a minute. So the injection for 70 microliters is between 3 and 4 minutes. And then they want you to hold the needle after the injection is complete for a minute, because their concern is if you pull the needle out too quickly, the stem cells will come back to the tract. So they want to give it time for it to hopefully diffuse away a little from the site. So it seems like forever, and I don't want to bore you guys with this, and I'll fast forward to let me see here. I'll fast forward a little here. So this video is only 5 minutes long, but it just...
Are you doing this with your hand?
Yeah.
It'd be nice if you had one of those things that where it'll bring it down and pull it forward.
Yeah, I mean, the problem is, and there's another study that I was on the safety committee for where they have a scaffold that they apply, but that's pretty great. You have to drill into the back of your skull because you need a framework. And we actually explored doing it for this study, but it just seemed like a lot of work and a lot of extra surgery. And so the freehand injection was done in the phase 1 trial, and people tolerated it just fine. Yeah, I mean, it seemed to work fine so far. We haven't had any issues with it. And I just want to show you the needle came out and there was no real problem with it. There was no bleeding or anything. And so, so our current status, and I've alluded to this, we had one patient in the cohort 1, which was not the efficacy arm, and we saw him back. He's from California, actually, so he flew back for all his follow-up. And he completed his one-year study, and I can tell you, I'm not, you can't really, you're not allowed to talk about the details of it, but I can tell you his results are promising. And so we have 3 enrolled in cohort 2. And the goal is to finish cohort 2 enrollment in 2016. So they're just looking for every site to enroll one more patient, and I think we'll be done. So in summary, again, I just want to focus on Drew's talks. Obviously everybody understands it's a devastating condition. There's a lot of ongoing treatments, and I didn't, so I wasn't involved in this study, but I know of several surgeons who are, and this is a neural scaffold. To me, it looks like styrofoam. I don't know what it looks like to you. But it's pretty small, and it gets implanted so you get an MRI, time of acute injury, you can see a little bright signal in the spinal cord. And that's where you think the cavity is going to form, because that's the injured area, right? So in this is also an acute spinal cord injury study. It's implantation, it's In Vivo Therapeutics is a company, and they have this product called neurospinal scaffold, which is this. So at the time of the initial surgery, so right after injury has occurred, there are surgeons implanting this into that right area. And this, presumably, at least in animals, will prevent that cavity from forming, which is a barrier toward regeneration. So that's another study that's currently ongoing. I think they've enrolled about 7 patients right now. So a lot of different studies out there. Yeah, that's it. So I'd be happy to answer any questions.
So currently the stem cell study, it's Asia A's and B's in first 24 months for B's.
Yeah. So yes. Yeah.
So will there be a future phase on more chronic patients? Will it then just be released to be used?
So I don't know. In part, recently they just want to focus on Asia B's, because when they try to screen AJs, there are too many screening failures, and the company's under a lot of pressure. So right now, their only goal is to finish that cohort 2, and hope that it's efficacious, and then they're going to make a decision on how they're going to proceed. It has to do with the problem with spinal cord injury in general, with let's say 12,000 incidences a year. It's not very prevalent, so there's no real push for big pharmaceutical companies or anybody to put a lot of money into it, because there's only 12,000 cases a year. So in some ways, it's considered an orphan disease. In Vertex, the company is doing an acute trial. The only reason they're not expecting to make money off of it. They just have a little arm. They're a good company that will devote a certain amount of money into problems. They feel it's almost like a charitable type of deal. So they're not expecting to make a huge return on this. And that's a problem with spinal cord injury in general. And with the stem cell study, their current investors are losing patience. And so they just want to finish the cohort 2, and then they'll make a decision which way to go on longer time points. There's this cohort 3, but they're not sure they can get to that. The cohort 3 with the Asia C's that they wanted to focus on next. So it's unfortunate, though.
Are there any preliminary results so far?
I'm aware of a little, but you're not supposed to talk to people. And what I'm aware of is not actually very detailed. I can tell you our one patient did fine, did well. I mean, he had noticed some improvement. And not just himself, it's just from the testing, he had improvement, like definitive improvement. So we don't know the phase 2 yet, because most of them, like I said, it's 2 to 3 months before half of them reach their 6-month time point. And not sure that you're going to see any difference before 6 months. I can tell you the first patient in our cohort 1 really didn't show a difference until this 1-year follow-up, because 6 months may not be enough time.
What's the possibility that this could turn into an NIH application for a follow-up if the company is worried about financial? Follow people.
Yeah, so I guess I don't know. I think the NIH really, I've been involved in a few NIH type of studies like that. It's just the amount of funding you get from NIH sometimes doesn't cover everything that you would need done. In fact, it often doesn't. So you need supplementary resources. And they're a public company. I think one of their issues is, if this doesn't work very well for them, their other projects aren't doing so hot right now. So I'm not sure where the company's going to go if this doesn't result in some promising results, after the, cohort 2 is done. And it's just, a reality. That's the reason why that first study, the Vertex, very promising result of the phase 1/2, but they couldn't proceed because the company didn't have any resources. So it lingered for years until Vertex actually. And I talked to Vertex. I asked them I was kind of curious why they're taking it on. They go, well, it has to do. They see a need. They don't expect to make a whole lot of money on it, but they just saw a need, and they have some resources set aside for what they consider, orphan-like diseases where there's not enough money being put into it. And they thought the phase 1/2A results were very promising, so they really felt like it would be a good use of the resources. That's why they're doing it. Potentially, I think so. I just don't know if the company's going to. NIH funding is so challenging. You have to apply, wait, 6 months usually, get a score. Yeah, from a research standpoint, yeah, I would be fine with it. But again, it's these stem cells are expensive to produce for one thing. The company has this proprietary way they harvest tissue. They have to go through this purification process for each of the patients enrolled. You just can't do it. They need 2 weeks of, acquiring the tissue, purifying it, getting in a format that it could be injected. So you definitely need the company's involvement. And I'm not sure NIH would give enough money for them. And but I agree with you from a purely research perspective. From my viewpoint, because I'm not a company, I would think, yeah.
Because we were just talking on Monday about research in MR, and the NIH strategic plan for 2016-20 includes that spinal cord injury recovery.
Right. Yeah, I know. I would, again, I think the company would have to be involved because they have their, they produce the cells. They have all the agreements to do it. I could broach it to them, but I think they're really more. They're commercial companies, so I think they haven't really focused so much on the NIH.
No, Michael Fellings is not in the Vertex. He was in the first study that you mentioned. Right?
He actually is. He's one of the primary motivators of it. Yeah. So at our research meeting, yeah, Fellings was. To him, the Cethrin, he was involved in the Cethrin study. He gave a little speech about it, and he said he was really disappointed that they couldn't proceed because of such the promising results, and he's very involved with Vertex now, and so they're going to be a site. They may have been the site that started, I don't know, but he's involved in the Vertex study. He was also involved in a stem cell study as well. He hasn't enrolled a patient, but they're one of the sites. Yes.
Talk a little bit about application of these two technologies in patients with non-traumatic spinal injury.
That's a very good question. I mean, that comes up. For our myelopathy patients, for example, you wonder if something like this could be helpful for them. It just hasn't been studied, so I don't know. I think for some of, for myelopathy patients, cervical spondylosis, high-grade stenosis, a lot of people feel the reason why you get it is, classically, at least in the neurosurgical literature, it's from a static mechanical problem, just the compression itself from the bone growth, a mechanical problem. So it may not be grossly unstable, but if you have a narrowed, like say stenosis around the spinal cord and it moves, you may just hit it and you get this quote microtrauma over time that results in injury. And the third is an ischemic phenomenon that occurs with the narrowing as well, and that's based on histopathology. After people have passed away and when they've sectioned the spinal cord, it looks like there's ischemic damage there. So those are the premise of the three kind of factors that cause this sort of myelopathic or myelopathy type of spinal cord injury. And if you think about it, maybe some of what's being done here could be helpful. I think when I think of Roe, I don't think so because that's more of a inflammation thing, but maybe stem cells. I mean, if the stem cells are really, and again, based on the animal studies, you inject them. It's not just them providing trophic factors, but it's actually the stem cells surviving, migrating, and differentiating into cells that are healthful. So I don't see why maybe something like that couldn't work, because this is in chronic spinal cord injury patients anyway, sort of like a myelopathy situation. I just don't know if it's been studied. I'm not aware of it.
And then thinking about that population, that's a much bigger group.
I mean, that's a good. I know. In this country, I know from surgery for cervical spondylosis, which includes that group. I don't know if they're all myelopathic. There's a couple 100,000 operations done probably annually for that. So it's a much bigger group, and I'm just not aware of anyone looking at it that way. I think for approvals, like when you're injecting stem cells, it's a lot easier to do it in this sort of population where bad spinal cord injury, maybe a little harder in our degenerative, spondylitic population, unless they're wheelchair bound or something, they're very profoundly functionally limited. A lot of our myelopathic patients are more mild or moderate. I think, but I think it's a good area. I mean, I would be interested in that, because often surgery doesn't help all their symptoms for myelopathy. All we do is decompress and stabilize them. So.
The injection that you do for the stem cells, is it the same way you do it for the Cethrin?
Oh, no, Cethrin is actually much easier. You don't have to open the dura at all.
You don't have to go into the...
No, it's, so that's, from my perspective, I like to study. It's really easy. You open the dura, injecting them is just more stressful for me because I'm worried about causing a problem. And, for the Cethrin, you just, we do laminectomies typically anyway for these, fractured patients. And you just put fibrin glue mixed with the drug right on the dura. That's it. Literally, it probably takes a minute extra time than I would normally use. So, to me, it's technically much easier to do. So, and it's interesting. I think from what I understand, and this actually comes from Michael Feelings. He's a big proponent of Cethrin. He really thinks it's going to make a big difference. So, I'm interested to see.
The other big difference is with Cethrin, you don't have the immunosuppression issues.
Oh, absolutely.
So.
Yeah, absolutely. So which I didn't actually get into because I didn't want to bore everybody, but these are allogenic. So the patients that we inject are on 2 immunosuppressants, mycophenolate and tacrolimus. And so there's a lot of downsides to being on an immunosuppressive medication. So they're on MMF for 30 days and tacrolimus for 6 months. And so you have to follow their levels. And obviously, being on an immunosuppressant, you may not heal well. You're more prone to infections and stuff. So, the Cethrin is a lot easier. No immunosuppressants or anything. I mean, I think if it works, that's going to be a great option. Okay.
Thank you very much.
No, thank you. Appreciate it.